Hello and welcome back for those of you who were here yesterday, and welcome anew to those of you who this is your first day joining us. Thank you for coming. As Jill and Beth and Joni all talked about, we're going to talk today about the biopsychosocial approach and how we apply this approach to everything we do in our start work. Really quickly, a breakdown of what we're going to do today. We're going to go over the biopsychosocial approach. We're going to do some breakout groups and then come back as a group and have some discussion. And I'm keeping my fingers crossed that our breakout rooms will work. If not, we will improvise and still have a discussion. Then we'll come back and talk some more about the biopsychosocial overview, have another case example and discussion for you all to engage in. So we talk a lot about biopsychosocial vulnerabilities in helping us to identify what is happening for the person and the system they live in. Why have they come to us? What are the factors that impact what's happening to that system and that person? First, we have to look at biological conditions first and foremost, then psychological conditions and social factors. These are all part of the person. They're all part of their learning history. They're all part of what has happened to this person to help them become who they are today. And oftentimes these are factors that unfortunately contribute to the problems that somebody is having right now. They interact in a very complex way. So this is a really complicated way to approach our work. I think that a lot of people talk about using this, and I know that in the trainings that we have provided around the nation, and even in the UK, some people have said, yes, I use this, but only at a very sort of overview kind of level, as opposed to digging in deep. So in the START model, we look very closely at all the factors that might impact biological health, psychological well-being, and social factors, all that intersect, and the complexity of how those things lead to mental wellness, mental illness and wellness. The START coordinator. So it is one of the central things that our START coordinators do is to help the whole system that works with this person understand how these different biopsychosocial vulnerabilities impact the person and changes in their functioning. We want to understand how a headache may play a role in an emergency or crisis. We want to understand how that person's trauma history impacts what's happening today. We want to understand how maybe something that happened yesterday that didn't go so well with a friend is impacting that person today. Our START coordinators ask the questions about all of the possible vulnerabilities that contribute to the person's difficulties. We have many tools and means for doing this, and for asking lots and lots of questions until we find all the potential contributing factors that lead to the challenges that the person is experiencing. Then we help the system identify as many of them as possible. So as a team, the system can work to sort of ameliorate all of those vulnerabilities so that we can prevent crises from continuing to happen. Mental health crises, behavioral health crises. We want to keep the person stable, or medical crises. And we also ensure that the START coordinators include a good understanding of character strengths, because we use this to help mitigate somebody's vulnerabilities. So when Jill was just talking to us about why it's so important to identify our own strengths, which helps us to identify other people's strengths, it becomes a sort of chain reaction. If we can start to focus on what's right, we can help people and their systems and people around them also focus on what's right and use those skills, strengths, interests to help overcome the difficulties that might also be occurring. We'll get into this more. So it's really important because it puts the behavior or symptom that we're seeing into context. It's not just that somebody is aggressive. 80% of people who are referred for START services are referred due to aggression. That doesn't really tell us a lot about what's happening for that person. That tells us even very little about the topographical behavior, right? It's just something that's happening. We know the person is upset about something, and that's about it. So when we can figure out all of the factors that might be contributing to the occurrence, we have a better understanding of the person, and we can help promote acceptance and empathy. So a lot of times when we begin to work with a particular system around somebody who's had challenges for quite some time and had a lot of crises, that system is burnt out. They're tired, they're frustrated, oftentimes they're hurt. And so in order to help those people also move forward, we want to give them hope that there are some things we can do. We can identify these factors. We can also start to build empathy for the person and what they're going through, that this person who is maybe aggressive very frequently or with a high intensity doesn't want to do this. This might not be their preferred means of interaction. We have to understand they're probably pretty miserable. So we need to help them figure out what's going on too. We use these things to guide our interventions. If we know better or have better hypotheses about these contributing factors, we can start to address them one by one. And then we check our data, right? As we address each of these potential factors, what happens? What is the change in the outcome for the person? And it also helps us identify a person's strengths. So a lot of the people that we work with, I know it's really easy to identify. They have a lot of perseverance. A lot of people we work with have been through so much trauma, so much stress, so much loss in their lives, and yet they keep going every day. And so we can help that person build on that. So obviously, I did mention there's obviously quite a complex interaction and interplay between and among all these different factors that impact somebody and their well-being. Very complicated. We have to take our time. It takes a lot of time. We really have to dig into the history for this person. We need to understand as much as their entire life of their entire life story as we can. We need to know what happened from beginning to now to understand how somebody ended up where they are here today, so that we can consider all of those factors. Word of caution is to never believe you have figured it out. We, as START teams and in our START network and community, really are really careful to think that we know something for sure, or that we have something figured out. We are continually assessing and reassessing our assumptions. And this makes me think about when Joni was talking yesterday about Donald, for instance. For those of you who were here, he was the man who had been institutionalized and had so much severe aggression that he had been moved around from place to place for years, was on a ton of psychotropic medications. And then when she and Bob got involved with working with Donald, they found out that he was having temporal lobe seizures, which were the precipitant. That was a vulnerability. That was a biological vulnerability that directly triggered his challenges. So once everybody knew that, they could take him off the medications that were lowering his seizure threshold, begin to actually treat what was really wrong, which was epilepsy. And he was a much calmer, happier man. And everybody else around him was as well. So we always have to ask more questions, think about more possibilities, continue to ask questions. So we're going to move on to Dr. Jen McLaren is going to talk about biological factors, but we wanted to test our little polling feature again today, and just wanted to ask you, true or false question. Here's the statement: biopsychosocial factors operate independently of each other. True or false? This is a kind of a gimme. Let's see. Yay, everybody's listening. That's great. Thank you. Not sure how to get rid of that, but I'm moving on. I'm going to let Dr. McLaren share her screen now, and look forward to hearing what you have to say, Jen.
Hi, thank you for having me. I'm just going to take a moment to share my screen here. Okay. So I have the
McLaren, I just wanted to make one comment on that poll. That everybody knew that it was false, but how many times have we said, "Oh, it's the constipation," or "Oh, it's their ID," or "Oh, it's their mental illness," and not treated people like they intersect? I just, we all know it, but how do we behave was sort of the question that I have,
We all want the easy answer, right?
That's
and
correct.
It's much more complicated than that.
Singular solution, right?
Yeah. So I will be talking about biological factors in biopsychosocial formulation today. So you may be asking yourselves, where do you start or where do you begin? Some people can be really intimidated if they don't have a medical background with biological, but it really is simple, and I'm going to try to make it simple for you. You want to start with initially the individual, and we'll talk a little more about that. But you always want to remember that individuals don't live in a silo, right? They have this whole team of people surrounding them who have really rich and interesting information about the individual regarding how they're doing. And this is not only true of people with IDD who are in crisis. This is true of people who are typically developing in the general population. When somebody is in crisis, we need to hear from many different people involved what is going on with that individual. We need to understand the individual and their baseline functioning. So what does that mean? That means, what does somebody look like when they're doing well? And describe that person. Tell me what they're like. What do they enjoy doing? What's a typical day like for them? And then you need to understand the change from that individual's baseline and functioning. When did that change occur? What does that look like? Lots of details regarding that. For example, if you have a 16-year-old who presents with ASD, an intellectual disability, and it's nonverbal, and they are in the emergency department and struggling with physical aggression and self-injurious behaviors, and you get a whole big long history about those behaviors, the key is, well, what does that individual look like at their baseline? To really do a good formulation assessment, you have to think about the baseline, because your formulation for somebody who has a long history of challenging behaviors since age 2, and the challenging behaviors have become more intense as they've gotten older, may be very different from an individual who has no history of challenging behaviors, and 3 months ago those behaviors started, and that they're really struggling with new acute onset behaviors. As a START team member, you always want to look beyond the challenging behaviors. It's our goal to look deeper than those behavioral problems, and by doing that, you want to think biopsychosocial. The first place to start is biological. Why do we start with biological? It's probably the simplest to start with, but it's also sometimes the easiest to change. And biological reasons can sometimes on their own cause the individual's presentation, but as Joni added, more likely contribute to the individual's presentation, right? There's lots of different things interplaying in that biopsychosocial model together. So if you read the literature, there's a common phrase in the literature that patients with ID may be poor reporters of their own health problems. And there's lots of data to support that, but I want to reframe that for you. And I think Joni, when we had a conversation about this conference, made me reflect on that statement. And yesterday she said something as well that made me reflect on that statement. I really think that we should reframe that statement and think about saying that we are poor at understanding patients with ID reports of their own health problems. right? We're not meeting them at their developmental level or their communication level, and we're not understanding their reports. Not that they are reporting poorly, we are not understanding what they're trying to tell us. Individuals may express their physical problems behaviorally. We want to take into account where that person is in terms of their developmental features, and that can alter their psychological and their psychiatric symptoms and also their physical presentation. We always want to assess new behaviors. We want to think about what is the change in the frequency or the intensity of previous behaviors and how that's changed over time. And all these behaviors listed down here: aggression, self-injury, tics, stereotypies, obsessive thoughts, compulsive behaviors, levels of attention, hyperactivity, impulsivities, fears, and phobias can be caused or can be exacerbated by underlying biological issues. There are 4 main categories to think about when you're thinking about biological issues. And as a medical profession, and when I was in medical school, I really liked mnemonics to help me remember all the different things I had to memorize. So my mnemonic for this is PGPM. I have 3 little kids, and we only watch PG films in the evening in the PM. So PGPM, physical health, genetics, prenatal environment, and medications. If you think about those 4 categories, you've really done a comprehensive overview of biological factors. And why you're learning this as a part of the START team member is you need to help push the system to think about all these different biological factors they may be missing. So individuals with IDD have higher rates of medical problems when compared to age and sex match controls. And this may be poor health, increased morbidity, so increased suffering due to those medical conditions, and earlier mortality. Health disorders in people with IDD can differ compared to the general population in terms of their prevalence, age of onset, how they progress the conditions, the degree of severity, and how they present. And this is important because medical professionals can be very busy, and they may not be well versed in all the different nuances on how individuals with IDD with certain medical conditions can present. And that's where a START team member can come in and try to advocate and help educate the system of care. We're going to go through all these different areas of medical problems somewhat superficially, and as you get more involved with START, I think you'll learn more about these over time. So this is a paper that was written by Lori Charlo. Dr. Charlo is a developmental psychologist who I've had the privilege to get to know through the START network, and I think that's a real strength of START, that you will meet many very talented, passionate people who know a lot about caring for individuals with IDD and are wonderful advocates and are doing really tremendous work. And Dr. Charlo published this paper, which I think is a really important paper, that looked at the non-psychiatric health problems among psychiatric inpatients with intellectual disabilities. So Dr. Charlo ran an inpatient psychiatric unit at UMass that specialized in caring for people with IDD. And they looked at 198 patients admitted to their inpatient psychiatric unit. And what they found was that 41% of the individuals had medical issues that seemed to cause the problem behaviors that led to the psychiatric admission. 41%. That's high. So I want you all to take a minute and close your eyes and think about the last time that you were physically felt pain, or you were suffering, or you were unwell. And I want you to take yourself to that place. And imagine that you cannot communicate how you're feeling to somebody else in your house, to your coworkers, to the other people you're spending your day with. No one else knows you're sick, so there's no one there to comfort you or to help you feel better or to help you seek the medical attention that you may need. Then imagine that you end up in a psychiatric inpatient facility because you were feeling physically unwell. I want you to write in the chat box how that makes you feel emotionally. that would make me feel terrified. The most frequent medical comorbidities that they found in this study was constipation. Constipation, right? A completely preventable medical problem, constipation. Constipation is also one of the leading causes of death for people with IDD. It's considered one of the fatal four for people with IDD. And then GERD, gastroesophageal reflux disease, heartburn. When I first started out, after I was in my training practicing, I had the privilege of caring for an individual with autism who had an intellectual disability and was nonverbal, and he had a huge psychotropic medication list. And he came in to see me, and he was struggling with self-injurious behaviors where he would bang himself in the chest really hard like this. And he would even take caregivers' arms and bang their hands in his chest, and he would punch objects, including punching his fists through the wall. And nothing was helping, nothing was making things better. And I asked about GERD and had he ever received treatment for GERD, because it was after one of my pregnancies with my first child where I really suffered from bad GERD, and Tums became my best friend, and I remembered how uncomfortable I felt, and I said, does he have heartburn? You know, like that horrible burning feeling. And sure enough, when he was started on omeprazole, his behaviors improved. And over time, as he became more physically comfortable, we were able to slowly deprescribe some of those psychotropic medications that he was on. So what we've learned from Dr. Charlot's study was that those admitted for an inpatient psychiatric care who had higher rates of medical problems also had longer associated lengths of stay on their psychiatric inpatient unit as they tried to resolve some of those medical issues. It's important to remember when you're thinking about a biopsychosocial formulation is pain. Pain in individuals with IDD is often under-recognized because of individuals' communication problems. And there was a study in 2013 that looked, and it was a systematic review where they looked at lots of different papers of how does pain present in individuals with IDD, and they found 4 indicators that can be quite helpful, looking at individuals' motor activity. So if there's a change in their motor activity, are they more active or less active? So what's the key here? You need to know the individual's baseline functioning. Also looking at an individual's facial expressions. Right? Has that changed? Are they less expressive? Are they frowning more? Do they have a furrowed brow? Is there an increase in social emotional distress? Are they more angry, more anxious, more withdrawn? Are they refusing to do previously enjoyable activities? And then lastly, looking at nonverbal vocal expression. So are they crying more? Are they yelling more? Are they moaning more? And these indicators can really help clinicians recognize pain in individuals with IDD, especially when we can recognize what is that individual's own pain response. What do they look like when they're in pain, and what do they look like when they're comfortable? We should know that for all the individuals that we're caring for. Dental pain is often missed and is one of the most common health problems among adults with IDD. And it is because of difficulties with maintaining oral hygiene routines, lack of access to dental care. So we really want to promote regular oral hygiene practices and other preventative practices by a dental professional, but we also want to look for, if an individual is in crisis, we need to encourage that somebody looks and examines their mouth. I have a patient in my clinic who I've followed now for years who has ASD, and we've recognized that there's 2 areas of pain for him that are really important that we've discovered that really escalate some of his challenging behaviors. One is dental pain. So he had a whole slew of cavities one time where he was really struggling with increased difficulties at school. And another is he's an avid swimmer, and he gets frequent middle ear infections. And one of the ways that we know he has an infection is that he becomes more withdrawn and sometimes more challenging in terms of aggressive behaviors.
Dr. McLaren, this is Beth.
Yes.
Some people are reporting hearing a little bit of a crackle in your audio, and so I'm wondering if you might be able to just, if there's any electronic devices near your computer, to just move them a little bit away.
Oh, my cell phone is. Yep.
Okay.
Let me move my laptop too. Sorry about that.
No problem. Thank you.
Let me know if it doesn't change.
Sounds good.
Okay. So also people with, there was another really great study of medical conditions that occur in people with ASD who present for an acute behavioral crisis. And this was a study, like Dr. Charlot's, that looked at records and charts of young adults and adolescents with autism who were hospitalized because of challenging behaviors. And what they found was that there are some common medical etiologies for acute behavioral crisis in people with autism spectrum disorders. And one of those is epilepsy. And we heard Dr. Beasley's story about the individual that she cared for who struggled with epilepsy that contributed to his challenging behaviors. And the other is painful medical conditions. It's also in this study they recognized that 25% of the individuals really had environmental causes that contributed to their presentation, which included lack of medical treatment for their struggles. And their conclusion in this study was that the management of these behavioral challenges really requires a unified, multidisciplinary approach. And that is where START comes in to help support these individuals with that unified, multidisciplinary approach with lots of different people supporting an individual and looking at lots of different aspects of their life and coming up with a full biopsychosocial formulation and treatment formulation. Other biological factors that contribute to physical health include sinus problems or headaches, sleep. So thinking about what does somebody's sleep hygiene look like, or are they struggling with underlying sleep apnea? We know that people with underlying sleep apnea can be more irritable or can struggle with symptoms of ADHD or increase in challenging behaviors. Does an individual have an underlying infection, like a urinary tract infection? Have their toenails been cut? So this recently came up at the Resource Center in New Hampshire, that an individual had really long toenails that were digging into his skin and were causing him a lot of pain. Whether there's been a change in vision or hearing impairment. So a change in vision or hearing can really lead to substantial changes in behavior and adaptive functioning. And then always thinking about, is there an underlying thyroid disease that can be contributing to co-occurring mental health issues? Beth, is the feedback better?
We're still hearing a little bit of a crackle. So it may be something to do with a microphone. If there's any objects near your computer microphone. The other secondary option is if you have a headset nearby, and if not,
you do.
Okay, let's try plugging that in.
Hello?
There you are. We can hear you.
Okay. So the G in my new mnemonic of PGPM is genetics. You want to think about family history. We know that if there is a family history of mental health issues, individuals in the family are then more predisposed to develop those mental health issues. So we always start with a history of first-degree relatives, siblings and parents, and then get a history beyond those first-degree relatives. You also want to think about the underlying genetic disorders. So some genetic disorders have an increased risk of having some co-occurring mental health or medical issues, and we'll talk about some of those. Fragile X, which I'm sure many of you will have individuals on your caseload with Fragile X. This is the most common inherited form of intellectual disability. Fragile X is a really complicated disorder because individuals with Fragile X have other significant co-occurring medical and mental health issues. And this is a study that looked at individuals with Fragile X and their co-occurring issues. So individuals with Fragile X overall, compared to a cohort of age and sex matched controls, had higher medication uses in terms of stimulants, antipsychotics, anticonvulsants, but also had larger teams of providers. 44% had visits to neurologists, cardiologists, otolaryngologists, gastroenterologists. 25% had speech and language therapy. 39% had physical therapy. 92% had an outpatient visit, 35% had an emergency room visit. What's really important is really coordinating all of this care. And it's important to have a team approach, and I feel like START really can assist with this team approach in terms of caring for these complicated individuals. We know that certain mental health conditions are more likely to occur in certain genetic conditions. This does not mean, though, that everybody with these genetic conditions will then develop these mental health conditions, that they just have a higher heritability or higher likelihood in this patient population. So, for example, bipolar, severe mental illness, is more likely to occur in individuals with Fragile X, Rubinstein-Taybi, rank 22, Prader-Willi. Certainly, individuals with Fragile X are more likely to have other co-occurring mental illnesses besides bipolar, like anxiety, ADHD, or autism. But I was just giving you an example of, what genetic conditions are more likely to occur in some severe mental health with some severe mental illness. Psychotic disorders are more likely to occur in individuals with Prader-Willi, cardiofacial syndrome, Turner syndrome, PKU, Klinefelter's, and autism spectrum disorder. We know that there is an overlap in terms of genetics in autism and psychosis. Both are highly heritable disorders. So, for example, autism has an 80% heritability, as does schizophrenia, and that's high. For example, heritability in terms of height from our parents is also 80% heritable. So those are just as high as inheriting the height from your parents as getting autism or schizophrenia. There are some overlapping genes that can cause both disorders, and these are some of them. And then also on a chromosomal microarray, we can look at, does an individual have shared copy number variations, deletions, or duplications that can predispose somebody to develop both autism and psychosis. You also want to think about what the prenatal environment was like for the individual. We know that alcohol and drug exposure affects individuals and their developing brain. We also know that alcohol exposure can cause something called fetal alcohol spectrum disorder. And even if somebody doesn't have the physical manifestations of fetal alcohol spectrum disorder, it can affect their brain development and cause cognitive limitations, ADHD, memory difficulties, difficulties with receptive and expressive language. We also know that these other factors, such as parental age, both maternal and paternal age, can predispose individuals to certain mental health conditions, as well as low gestational weight gain. Maternal stress during a pregnancy can predispose to mental health conditions, prenatal viral infections, and then even maternal micronutrient deficiencies before and during the pregnancy. And then where I want to spend some time is on the last category in biological factors, which is medications. We know that many individuals in START are going to be on medication regimens, and they're going to be on fairly complex medication regimens. And it's important to think about, are these regimens beneficial? And some may be, right? Some individuals may be treated with a medication like an SSRI that may be treating their underlying depression. But some individuals may be treated with medications that may be causing side effects, adverse drug reactions. There may be drug-to-drug interactions. Individuals may be on lots of medications, like 2, 3, 4, 5 psychotropic medications at a time. We also need to look at misdiagnoses and misdiagnosis, and we'll talk about that a little more. And then for me, this is really helpful when I'm working with a START team to making sure that the individuals on the team and the individual and their caregivers have realistic expectations for medications, right? There is not a magic pill out there for any mental health disorder, right? Even for, say, risperidone and aripiprazole, which are FDA approved to treat irritability with autism, that's not a magic pill. The studies show that for some individuals with autism, those medications may decrease irritability by about 50%. So if caregivers think that that pill is going to make all challenging behaviors go away, right, that's when we see lots of different medications being added when we don't have realistic expectations on what medications can do for an individual. We know that antipsychotics and polypharmacy are really prescribed for individuals with IDD at high rates. This is very true for individuals in START. And it's important to recognize that there is a lack of research support and many individuals are not adequately monitored for treatment with antipsychotics and polypharmacy. What's also a concerning practice is the long-term use of these medications. For example, there was a study in children with autism, and they found that the median length of polypharmacy for children was 346 days. Never mind that, for some of these young adults and adults, some of them have been on these medications for years, and it's not clear if they're helping or not. So certainly we want to think about that individuals with IDD are more sensitive to side effects of psychotropic medications. They're more likely to have adverse reactions, and that can affect the presentation of the individual. So when you're thinking about the biopsychosocial formulation, you want to think about, is this behavior a side effect or an adverse reaction to the medications? We also know that the treatment studies of these medications have been done in studies that don't really replicate the real world settings for where our patients are living, and many of our patients with IDD have been excluded from the studies. I want you to think about when you see antipsychotics on a medication list, if the individuals that you're caring for are experiencing any of these medications and whether the benefits outweigh the risks. You want to think about weight gain, metabolic abnormalities, sedation, tremor, somnolence, restlessness, right? So restlessness can be a really uncomfortable side effect and can contribute to challenging behaviors. We had a patient recently in one of our clinics who was newly started on a risperidone in the community and titrated up very quickly. And the patient came into the clinic and was in crisis and was pacing back and forth and couldn't sit down. And it was clear that they had restlessness known as akathisia from the risperidone. And then extrapyramidal symptoms, which can be quite concerning, such as tardive dyskinesia. We have very little evidence to know how these medications affect the developing brain in terms of the neurodevelopment of children. And certainly we need stricter oversight and improve clinical practice to reduce the harms of these medications. We want to recognize and educate the systems of care that we're working in as part of START, that even though psychotropics are commonly prescribed, their evidence base to support their use in people with IDD is very limited. There's not a huge research evidence base to support the use of these medications. The medications that do have evidence in terms of their safety and tolerability are poorer for people with IDD than the general population. For example, when we look at stimulants for children with autism who have co-occurring ADHD, about 18% of children who are treated with a stimulant who have ASD have an increase in irritability compared to like 2% of typically developing children. These challenges are partly because there's a wide range of phenotypic and genetic heterogeneity in individuals with intellectual disability, right? So Joni said yesterday, if you've seen one person with autism, you've seen one person with autism, right? People are vary greatly, so it's a patient population that can be more challenging to study. It's really difficult to measure how these medications affect the cognition of individuals. The studies that we do have are short-term, typically 8 weeks. I don't know anybody who's typically on a psychotropic medication for only 8 weeks. The studies do not generalize to the non-clinical settings very well, and we do need to research how we use these medications in people with IDD better. So as a START coordinator or a START team member, when you see somebody with psychotropic polypharmacy, you want to think about these 5 disease factors, or these 5 factors, which are not discrete or independent. They all interact with each other when you're trying to formulate how did we get to the polypharmacy and how do we help resolve it. So there's disease factors, there's patient, there's caregivers, there's physician prescriber, and there's system, if you want to resolve the polypharmacy. So in terms of disease factors, it could be that the individual has refractory disease, and that refractory disease can be a medical issue or a mental health issue that's really difficult to treat. So for example, somebody may have really difficult to treat depression or really difficult to treat schizophrenia that may respond only to multiple psychotropic medications. The next would be suboptimal treatment. Is the individual receiving optimized treatment for the condition they're being treated for? So for example, if they're being treated with an SSRI for depression, but they're still depressed, has that medication been increased to an adequate level to treat the depression? What about side effect management, right? Is the individual being treated with multiple medications to manage the side effects of the other medications? So, for example, individuals on antipsychotics may have weight gain, and then they may be started on another medication for weight gain, and they may have restlessness, and they may be started on another medication to manage the restlessness. Do we have the right diagnosis, right? So if we're treating depression, are we sure it's depression or something else not going on? Or is there another diagnosis that we're missing and we're treating the wrong thing, right? Are we treating depression, but the individual's really struggling with significant substance abuse that needs treatment first? I thought this was interesting. Medication-related problems or adverse drug reactions are estimated to cost the United States $200 billion annually. And if adverse drug effects were classified as a distinct disease, it would rank as a 5th leading cause of death in the United States. The 5th leading cause of death because of adverse drug reactions. We also want to think about patient and caregiver factors. The first one to think about are medications being taken as they're prescribed? And then we want to think about personality style, consumer choice paradigm, and illness behaviors. And these are all sort of interact with how does somebody think about medications, right? The patient or caregiver. Are they looking for that magic pill? And do they choose medications over other interventions? For example, if they're struggling with depression, do they want a medication first before they want to engage in therapy? And their illness behavior is every time they get sick, what do they try to do, right? Do they look for a medication, or do they look to take some time and rest and get better? And those can influence polypharmacy. So sometimes we need to provide some, as a team and as a START coordinator, some psychoeducation to a caregiver or family or a treating team. And then we want to think about physician prescriber factors. Some physicians will do symptom-based prescribing. So instead of trying to do a full biopsychosocial formulation, they may be treating lots of different symptoms with different medications and looking at the big picture and what needs to happen or change. Some physicians will see themselves as a powerful healer. And if that's true, they can get caught in this trap where they're looking to fix everything with medications when we certainly know that there's many things that medications cannot solve or fix. And then some physicians are afraid of, or prescribers are afraid of, fear of patient dissatisfaction, right? If somebody comes into you and they have a viral illness and they're looking for an antibiotic, you may be afraid that if I don't give them that antibiotic, they're going to leave here dissatisfied. And as a prescriber, you have to feel comfortable with that and providing psychoeducation regarding what you believe is going to help the individual get better. So the World Health Organization said that few healthcare professionals have the specialized training and expertise and skills to assess and treat individuals with IDD. And that is where START can be really helpful in helping to become partners with healthcare professionals to provide better care for individuals with IDD. We know that there are system factors that contribute to psychiatric polypharmacy. We have a really complicated and fragmented healthcare system, and individuals with IDD are involved in multiple different systems, and sometimes the systems have poorly integrated service systems, which leads to really fragmented or inconsistent care, and a limited understanding of the individual and their functioning in the different environments. And this is where START is tremendously helpful in bringing the system together. Sometimes also other outside stakeholders can influence psychiatric polypharmacy. Certainly, as a prescriber, I have had school teachers and school principals call me and say to me, this child is not on the right medication, you need to add something else. So sometimes it's engaging those other service systems and providing education and a good biopsychosocial formulation on how we can help things get better for the individual. So I encourage all of you to ask these 4 questions of prescribers when somebody's on a complex medication regimen or on any medication. And I encourage you to do this for yourself, for your loved ones, and certainly for the individuals with IDD who you're caring for. In terms of what do we do with psychotropics, we utilize the same evidence-based treatments as we do for typically developing people for many different psychiatric conditions, because that's where the majority of the research evidence is. So for depression, for anxiety, even for schizophrenia and bipolar we rely on that evidence base. We typically want to start low and go slow, not to induce significant side effects. We always have to think about the side effect profile and the medical comorbidities, right? Because this is a complex patient population with, who may have lots of different medical comorbidities. And then the last area that I wanted to talk about was the individual's disability. And I believe Jill and Karen are going to talk a little more about this, that you want to have a good understanding of the individual's disability. And this falls into both the biological and the psychological realm, and even the social realm, that you want to understand how does the individual's disability impact the individual and their family environment, including how does it impact their health. So here are the things that we've talked about in terms of biological. And I have a polling question. Common biological factors to think about in our formulation for individuals with IDD include GI issues, dental pain, medications, sleep, or all of the above. Wow, you guys listen. Good job, 100%. So I'm just trying to, so remember our 4 biological factors that you want to think about as part of your biopsychosocial formulation. I think I'm going to head to the vignette because I know we are close to time on this session. So here's, go ahead.
I think we might, Beth, were you going to maybe give a few
There's a
minutes
few,
to questions?
yeah, there's a few questions,
Okay.
Dr. McLaren, if you don't mind.
Sure.
So the first question is, would you mind describing the work of your multimodal team and how you work with START, since these are similar teams are being developed in California?
Great. So our multimodal team is, number one, hands down, one of my favorite clinics that I have the privilege to be a part of. We have a multimodal team in New Hampshire at Dartmouth, where a START coordinator refers an individual to a team who they think would benefit from a very thorough consultation. And at that appointment, the individual is invited to the appointment, and the START coordinator then invites the rest of the team. And we encourage the START coordinator to invite as many people who are involved in the individual's care. So we've had schools participate, other psychiatrists, primary care doctors, certainly day programs, residential programs, and we see an individual with myself as a psychiatrist, a neurologist, an internist/pediatrician, a neuropsychologist, and an occupational therapist. The START coordinator meets with the team ahead of time and gathers as many records as they can. They also meet with the team to formulate their questions for the team, and they reach out to the individuals, typically their primary care doctor, their psychiatrist, or any other treatment providers who may have questions that they'd like the team to answer. The team spends a lot of time reviewing those records ahead of time, and then we meet with the individual and their team and get more history. The individual then receives a physical exam. They meet with our occupational therapist individually and a neurologic exam, and we write a very comprehensive report that goes back to the START coordinator. The START coordinator then meets with the individual's team, and they develop an action plan on how they're going to proceed with the recommendations. Usually the reports are fairly long, and there's typically several pages of recommendations.
Wonderful. Thank you very much for that overview. A couple of other questions.
I just want to add one thing to that. This is Joni. So because we have found that New Hampshire, which has a multimodal team, has fewer crisis contacts than any other statewide START program in the country. And we really feel that the multimodal team, Dr. McLaren's team, contributes to more proactive strategies to prevent difficulties from being exacerbated, and that it's done a great deal to contribute to the success of supporting people in New Hampshire. So we're very excited that California is going to be doing that in several of the regional centers.
That's great.
Jen, perhaps a couple more questions?
Sure.
Okay. We had a question from Lauren. Any recommendations for how to assess vision and hearing in clients who cannot report what they hear or see?
Certainly working with a good optometrist or ophthalmologist. And I have personal experience with this in a good ENT. They have techniques to do that with some of the technology that they have. So for example, there's an eye condition that runs in our family that caused a disorder in one of my children, and they were able to look at my 18-month-old vision, and she was not able to report on what that looked like or how it was. So I think working with, but also looking at, in terms of like in the community, changes and things that the individual was previously able to do. So thinking about what the baseline is and how's that changed in their everyday living is the first and earliest sign, since then realize that we need to go see a subspecialist.
Thank you. The next question comes from Janet, and she asked, how important is a microarray for an individual with autism spectrum disorder?
It's really an individualized decision. So the American Academy of Genetics and the American Academy of Child and Adolescent Psychiatry have all given out consensus statements that the standard of care is to offer a chromosomal microarray for individuals newly diagnosed with autism. And in about 15 to 20% of individuals with autism, there'll be a finding in terms of a clear genetic etiology for why that individual has autism. It doesn't always change the care, and certainly for families, I feel like that's a very personal decision. So we offer that to families, but we don't push it, because that's information that they may want to know or they may not want to know.
That makes sense. Okay. Janet also asked about any suggestions you might have on how to best check for seizures if the person can't tolerate a typical EEG.
It really depends on lots of other things, and depending on what kind of seizures you're looking for. So typically it's based on history, and again on what does a patient look like at their baseline, and what does the potential seizure activity look like. And different seizures will manifest in different ways. So for younger people and absence seizures, those might look like, lots of different staring spells all throughout the day, versus grand mal seizures are much more obvious, where they may have loss of bowel or bladder and might bite their tongue. So, I mean, I think your friend always, no matter what medical etiology you're looking for, whether it be seizures or change in vision or even constipation, is what does this individual look like when they're doing well? And what do they look like now? And what's my hypothesis for that change? And you're gonna make several hypotheses, and then you're gonna test them out, whether this is right or wrong, and whether we should go down this route and pursue it further.
Jen, this is Karen.
Go ahead.
I was just going to say that a friend of mine who suspected her son was having seizures, but was having a real difficult time getting an EEG, she started videotaping episodes where she thought maybe he was having seizures. Just on her phone, she just recorded it and then took that to the neurologist, and he found that really helpful, and he did identify the type of seizures her son was having through that.
That's a good point. So we recently had a very similar experience where, as part of the multimodal clinic, we were doing a telehealth evaluation, and the individual was in the car, and the parents were saying that he was having his typical challenging behaviors, and our neurologist was watching them, and she was so glad she was able to see him in his regular environment, because she's like, oh my gosh, these are probably seizures. And he was somebody who wasn't able to tolerate EEGs in the past. So we were going down that route of recommending treatment for these hypothesized seizures.
I think we have time for one more question. The question was, how often should medications be evaluated to check effectiveness?
Well, certainly, I am of the thought process that you never start a medication without an exit plan, right? So you always want to have a discussion with the start of medications. Number one, an understanding of why you're starting them and what you're treating and what you're going to expect to get better. And then once things are better, your exit plan typically is to taper. So for most disorders, so for example, for depression and anxiety, once those are improved, the recommendation is that then you do after 1 year of stability, you taper the medications. If somebody has a true diagnosis of schizophrenia and bipolar, those recommendations are a bit different. So it depends on the diagnosis and what you're looking for. Individuals typically should be seeing their prescriber regularly to be monitored. So typically at least every 3 months. If you're starting a new medication and increasing it, typically more frequently than that. Does that answer the question?
Thank you, yes. Okay, I think we're ready to transition to the breakout vignette.
Okay. Do you want me to read it or just show it on the screen?
How about we read it?
Okay.
And the vignette also is posted on the webpage for those of you who are interested in having a copy.
So John is a 13-year-old male with autism, ADHD, generalized anxiety disorder, and mild intellectual disability. John communicates using fluent conversational speech. He loves playing video games, and he is very good with technology. He has a close relationship to his mother, Janet. Janet is a single mother, and she loves John very much. At his baseline, John is typically happy and enjoys spending time with his mother. John struggles with a long history of physical aggression that has recently increased dramatically in frequency and intensity. The aggression occurs at both home and school. John's mother notes feeling overwhelmed caring for John as she works full-time as a secretary and is often called to pick John up from school due to his challenging behaviors. John overall seems more moody and irritable. John last saw his PCP about 9 months ago when he was having irregular bowel movements, and he was treated for constipation. John has a restricted diet, he is a very picky eater, and is overweight. John has not seen a dentist in years. He is also a poor and restless sleeper. He sees a psychiatric nurse practitioner every 3 months and is treated with multiple psychotropic medications with little benefit noted. John's medications include quetiapine, citalopram, Concerta, and buspirone. John's parents separated when he was 6 years old. His father struggled with depression and alcohol abuse. There was domestic violence in the home from John's birth until he was 6 years old. John has not seen his father since their separation. So we'd like you to discuss these 3 things: the biological factors in the case example, discuss the psychosocial factors in the case example, and what else would you want to know?
Hello, everybody, and welcome back to part 2 of today's biopsychosocial overview. And I'd like to introduce Center for Start Services Clinical Director, Dr. Jill Hinton.
Thank you, Beth. Glad to have everybody back. So we'll continue on with our discussion about biopsychosocial factors in formulation. So I'm going to move into more of the psychological factors, and really appreciate Dr. McLaren's descriptions this morning of some of the biological considerations. And you'll obviously notice, and as Karen told us when we first started, all these interact and overlap with each other. So we kind of artificially divided them among ourselves, but you'll see as we go through that certainly they all interact and build upon each other. So what I'm going to try to cover in my time is some of the common psychological vulnerabilities that we see in the folks that we serve through START. So I'll talk about IDD diagnosis, we'll talk about executive functioning deficits, psychiatric or mental health disorders, trauma, and a concept about cognitive reserve. So first, START is a mental health model that is for people with intellectual and developmental disabilities. So the people that we serve all have a developmental disability. This is just the federal definition, which you're all familiar with. And the folks that we serve have an intellectual disability or autism spectrum disorder. We do have a large percentage of folks that get referred to us who have autism. And the role of the START team is to look at the level of intellectual disability or the associated issues with autism spectrum disorder, but to go beyond what we typically look at. So the point I want to make from this slide is that as we think about folks who come with developmental disabilities, we're looking at much more than what their IQ is. The START teams are always asking for more records to review and really want to see the psychologicals that have been done, the assessments and the evaluations that have been conducted, and want to read through the reports because we want to learn as much as we can about the adaptive functioning for that person. As most of you are aware, that the DSM really for intellectual disability focuses more on that adaptive functioning as kind of the gold standard for how we determine level of intellectual disability, no longer just looking at that IQ number. And that IQ number, if a single number really doesn't tell us anything about that person, we really need to dig a little deeper about what the strengths and weaknesses are of that particular person. Just to kind of point out, and many of you work in this field, so you already know this, but when somebody is referred to us with an intellectual disability, there's certainly some strength and weaknesses within that profile, but generally with intellectual disability, there's some similar difficult areas across different, similar functioning levels across different areas, cognitive, social, adaptive. There's some scatter, but not much. But when you think about people with autism, you often see a broader scatter of skills. So maybe more difficulty with that social and communication area, and then some other really high strength areas. But a lot of concrete thinking. So this is all these are all things you all know working in the field. But I think the point I wanted to make with this is that we always want to dig a little deeper as a START team and think about what this diagnosis means for that person, because a diagnosis by itself does not drive us to know how to create strategies or treatment for somebody. We really have to go beyond just that diagnosis. But we do want to consider what the effect of a developmental disability has on a person. So often we think more about that person's executive functioning. So a lot of studies that have been done have shown that people that have a developmental disability of any cause have some differences or deficits in their executive functioning. So what do we mean by executive functioning? So a very simplistic definition is this set of mental processes that really helps us connect past experience with present action. And that is a good description of being able to use what you've learned in the past, experiences you've had in the past, to impact how you are responding in the current moment. And having this ability really helps us to adapt on a day-to-day basis and be able to respond to unexpected situations that come up and make alternative plans. So when something interferes with our routine, we can stop, think about it, problem solve, adapt, and make some alternative plans or routines to get around that unexpected event. So it's something that develops over time. In a typically developing person, this begins early in life and develops over through early childhood, adolescence, and up into the mid-20s. So generally, executive functioning is not fully formed until the mid-20s, about 25 years old. Those of you who have, well, we've all been teenagers, and some of us have had teenagers in our life. You can attest to that ability to let past experience affect your present action is not always there in teenagers. But so thinking about it from that perspective, but it is developmental and it does develop over time. So a little more specifically, what does it kind of allow us to do? There's lots of definitions of executive functioning out there. And they explain it many different ways. This is a presentation I heard from a man named Ken Benedict talking about executive functioning. He kind of looked at all these different definitions, all these ways to describe it, and put it down into these specific things that executive functioning allows us to do, which to me make a lot of sense. To be able to start an activity, start a task, get something started, to be able to stop that when it's appropriate to stop, to know when you need to stop, to know when something is finished, and when you need to move on to something else. To change and shift, and we just talked about that earlier, to be able to adapt, change, shift, transition, move from one activity to another, change your perception about something, change your understanding of something. He defines hold as being able to use your working memory. So again, thinking about past experiences and putting what you've learned in the past together and working it around to be able to plan and to adapt to something new. Modulate, to be able to modulate and adapt and to things that are external to you. So what a very simplistic explanation would be like just noise that's around you, right? So lots of activity around you, being able to kind of screen out what's important, know what to pay attention to, and be able to screen out the things that are not important. So modulating that, and also modulating internally too. Being able to organize your own space, organize yourselves in space, organize to be able to get started on a task. Orchestrate. Some people actually call kind of your executive functioning as kind of the conductor of the orchestra, but being able to handle different things at different times and know the best time to say something and the times that you're not supposed to say something, know how to kind of navigate through life. And then to monitor yourself, to be able to self-regulate and to inhibit. So those, to me, kind of distilled down a lot of different executive functioning definitions that are out there. The ones that are highlighted and are bolded here are ones that I think kind of stick out in terms of a lot of the folks that we support, that really cause a lot of difficulty sometimes. So the transition from one activity to another, so that change and shift, to be able to handle unexpected things that come up, to be able to use your working memory when you encounter a difficult situation, and then that monitoring and self-regulation inhibition, which Karen mentioned when we first started, that 80% of the people that are referred to for START services have some type of physical aggression, property destruction, those kind of externalizing behaviors related to some of this executive functioning deficit that's there probably. So when these kind of deficits exist, what do they look like? And these will sound familiar to you if you work with folks with IDD and co-occurring behavioral health needs. Some of these things we do see in folks. So impulse control, we talked about that in terms of inhibition, right? So sometimes people will blurt out inappropriate things, say things that, and we all do this at times, right? So say things that we shouldn't have said, and we're like, oh, that was not the right thing to say at this point. And when our executive functioning is not working well, we sometimes do those things. Take risks, strike out at others. And then that control kind of bleeds over into kind of that emotional control. So being able to deal with strong emotions without overreacting is part of executive functioning. So when some of the folks we work with, we see that overreaction to something that we might consider something insignificant, but they overreact to it, or dealing with criticism or things not going right. When things go wrong, how do folks deal with that? And sometimes we see a very strong emotional reaction to those things. The flexible thinking, adaptation, problem solving, being able to see things from a different perspective. And I mentioned working memory before, but again, that being able to use what we've learned in the past to affect our current situation is really one of the key parts of executive functioning. So that affects the ability to kind of, in a moment, understand cause and effect. And that is something that we see in a lot of folks who, I think Jen mentioned fetal alcohol spectrum disorder. That deficit in that disorder is pretty prominent. So you have folks who cognitively, or in terms of their intellectual functioning, are functioning in the mild to kind of borderline range, but have a really difficult time in this understanding cause and effect. And you'll see that when in that population of folks that have fetal alcohol spectrum disorder, often involvement with the legal system, because they make decisions in the community that get them into difficult situations. A few other things: self-monitoring, and kind of monitoring their own behavior and how that affects others, planning, prioritizing, being able to start a task, initiate a task, know where to begin. And often, and you'll see this, I see this a lot in folks with autism, of just needing some initial prompts to get started, to know where to get started with something. Once they get started in the activity, they can continue, but kind of knowing when to get started, how to get started is often very difficult. And just basic organization. And if you think about all these things, as I said, they all are things that develop over time through childhood, adolescence, into adulthood. But there's things that impede upon this executive functioning for all of us. When we're highly stressed, when something totally unexpected happens, we all can lose our ability to use our executive functioning for brief periods of time. Say something we shouldn't have said, lash out at somebody that is really not responsible for what's going on. We do all those things, and we usually, for us, we can we respond that way, but we then can quickly recover and figure out, oh, I shouldn't have said that. You apologize to somebody and kind of take a deep breath and get back into where we can function from our executive functioning part of our brain. But for folks with intellectual and developmental disabilities, it's sometimes harder to initially inhibit, and because of these deficits, and then once something happens, kind of harder to recover and come back and use some of your executive functioning. So again, this is something that with all the START teams, we really try to emphasize is regardless of what that developmental disability is, to think more intently and be curious about what does that mean for this person in terms of kind of where they're functioning in their executive functioning realm. And as we do that and kind of analyze, investigate, evaluate, assess, we want to determine what some of those executive functioning impairments are, and then what type of structure supports are needed so that the person can more effectively get through their day. So generally, the greater those impairments, the more external structure folks need. And I just want to point out that we all use these external structures, right? Where would we be without our Outlook calendars or our iPhones or the little dings that remind us that we need to do something? So we all use these on an everyday basis. For folks with intellectual and developmental disabilities, sometimes don't have access to those type of structures, and so we need to think about that as we develop strategies and treatments for folks, and think about where they are in terms of their executive functioning impairment. And if we don't consider this, I think it often leads to misinterpretation or misdiagnoses, people having unrealistic expectations of someone. So executive functioning doesn't always correspond with that person's measured level of IQ, for example. I mentioned fetal alcohol spectrum disorder. That's a great example of where that often doesn't match. It's true with autism often. Folks with autism could have great memory for lots of things and have a lot of knowledge about a lot of subjects, but have difficulty when things go wrong or things don't happen the way they think they should. I once worked with a young man who had autism spectrum disorder, had his driver's license and was working at a part-time job. He had to be there every morning at a certain time. I can't remember, maybe 9 o'clock. But did require a lot of external structure around getting up and getting to work and those kind of things. And he didn't show up at work one morning, and people were concerned about him, tried to call, he didn't answer the phone. If somebody finally went over, he didn't call either to say, I'm not coming to work or something's happened. But somebody went over to check on him, and he had a very structured routine in the morning of what time to get up, what time to eat breakfast, what time to take a shower. And he had done up to a certain point, and he got in the shower and he didn't have any shampoo. His shampoo was gone. And he stopped and didn't do anything else. He just stopped and didn't come to work, didn't call anybody. And this is a person that folks would get very frustrated with, because they're like, oh, he should know that. He knows how to do that. So people would think he's being manipulative or attention seeking, or some of those words that we don't like. But he really got stuck, and he couldn't use his problem solving skills to figure out what to do next. So it just means we have to put more external structure, more cues around him and solutions around what happens when things like that happen. So to help him to know, we put a line on his shampoo bottle so that when it gets this low, that means you've got to buy some more before you get to the bottom, giving him instructions about who to call if something like that happens. So again, important to assess where the person is in terms of their executive functioning, because it can lead to some other significant issues if we're not well aware of that. So as I said before, START is a program designed for people with intellectual and developmental disabilities, but it is a mental health model, right? So we also consider psychiatric diagnosis. So we know that individuals with IDD can exhibit the full range of psychiatric disorders that are experienced by people without disabilities. The most commonly occurring ones are trauma, depression, anxiety. Depression and anxiety are the most common ones in the typical population, neurotypical population, and they should be the most common ones in the population of people with intellectual and developmental disabilities. Bipolar and schizophrenia are far less common, but are pretty significant when they do occur. This may not match what you see in the community, and it doesn't always match what we see in terms of people who get referred to start. So we see diagnoses of schizophrenia and bipolar far more frequently than we would expect. And sometimes people are missing some of the more common diagnoses, such as depression and anxiety. So it's really important for us to pay attention to this and to think about, what is realistic to see. Dr. McLaren earlier mentioned that people with autism share some genetic things with psychosis, right? There's some overlap there.
Yeah.
So psychosis or schizophrenia may be a little more common in people with autism than in the neurotypical population, but it's still not the most common diagnosis that you should see for somebody with autism spectrum disorder. They're much more likely to have anxiety or depression. So again, something that we want to see change over time, and as we learn more and help systems understand better about people with intellectual disabilities, what different psychiatric diagnoses look like in that population. The other thing I'll just point out is that there's a tendency in the system, and probably for a lot of reasons, maybe funding issues or service issues, that we want to identify a primary diagnosis for some reason. But if you really think about that, it doesn't make a lot of sense. A person is a person, and they come with maybe a level of intellectual disability or autism spectrum disorder. They may also have depression. One is not primary over the other. They both interact, just as we talk about biopsychosocial interacts. They both interact together to create the pattern of presentation that we see for that person. So we try to avoid kind of thinking which one's primary, but to see that person as a whole person. So we know that 30-40% of all people with IDD do have a psychiatric disorder, and that's compared to about 27% of the general population. 10 to 20% have challenging behavior, some of the things we talked about before, that's severe enough to kind of impair their daily life or their ability to access their community and to participate in daily life activities. That population is the population that often gets referred to start. And again, we'll talk about why that is the case. So if we know that percentage of folks do have a diagnosed psychiatric disorder, but we also know, just like I mentioned, that often the diagnosis they come in with is not correct. So we see underdiagnosis of some things like anxiety, and overdiagnosis of other things, or an inappropriate diagnosis of other things. And that's because the symptoms of some of these psychiatric disorders often present a little differently in people with intellectual and developmental disabilities. And sometimes it gets more complicated when the level of intellectual disability is more severe. It gets a little more complicated to make the right diagnosis. I don't know why this is like this, but some of the reasons and things we have to consider when we're looking at psychiatric diagnosis is to think about the ability to understand questions and answers. And we describe this often as intellectual distortion. So being able to understand the meaning behind what's a question somebody's asking you. So a really common example is that whole question that often people get asked when they show up in the emergency room or for mental health crisis services of do you hear voices? And that question can be answered really concretely by a lot of people with autism or with intellectual and developmental disabilities. So if you just say, do you hear voices? They're going to say probably yes, because they're hearing people talk to them. And also not understanding the context. So if you or I or somebody went into an emergency room and somebody asked us this question, we would figure out why they were asking that question, right? So they're trying to determine whether we're having hallucinations or we're hearing voices, or are we psychotic? And so the question just asked out of context for somebody with IDD, they're going to answer it on a very concrete level. The difficulty, again, with expressive and receptive language, we'll reframe that. I think Dr. McLaren reframed that earlier. So part of that is on us, right, to make sure we're listening in the right way. So I often like to talk about communication as, we all know communication is a two-way street, right? So when I was studying in graduate school, I will never forget a speech language pathologist talking about that. She said, we never describe the person that's coming to us as having a communication deficit, because communication is two people, it's not just one. So if there's something that's not right, it's on both of us. It's not just one person's problem, right? So we have to take responsibility to make sure that we are listening in the correct way to what people are trying to tell us. We do know that it's difficult sometimes for people to, in the same way we would, or same way I would perhaps, describe how, if I felt depressed, it may be described in a very different way. So we have to listen more stringently to what people are trying to tell us. The other thing is that people with IDD may often feel pressure just to say yes to questions, just due to power imbalances in the way that we historically in the IDD system have focused on kind of a compliance environment for people with IDD. So in a situation where somebody is in a hospital or in a crisis setting, they just may feel very anxious and pressured to be able to try to please people or to give the right answer. And again, kind of historically is what we've done within our systems. And then just because of some of these things, sometimes people's presentation doesn't match what would be shown in the general population in terms of a diagnostic criteria. So things get misdiagnosed. So somebody who's experienced trauma in their life may be reliving some of that trauma and talking about it in ways that people can understand, and be misdiagnosed as having psychosis, for example. Somebody who's very anxious and is having difficulty going into the community or doing things that they used to like to do can be seen from a behavioral perspective as kind of non-compliant. Again, we have this history in our IDD system of focusing on compliance, which is not what we want to focus on, but sometimes that's the way people are described, as opposed to thinking or wondering or being curious about, I wonder what they're anxious about, I wonder what they're afraid of in this situation. So those kind of misinterpretations can lead to some of that misdiagnosis that I talked about earlier. So with all of these things, considering diagnostic issues, executive functioning issues, all of these things lead the START team and the START coordinator into thinking about how they're going to proceed in terms of formulating what's best for that person and how do we develop strategies. And I hope you heard that it's more than just about an IQ or a single diagnosis, but around lots of considerations that we have to think about as we're reviewing assessments and doing more assessments for folks with ID. I think there's a polling question coming up. There it is. Diagnosis is the same as formulation. True or false? Great. So, diagnosis gives us a part of what we're looking for, right? So it can lead us to know some things about a person, but I would like to think about the fact that a diagnosis doesn't lead to treatment planning very effectively. And what we want to do with really developing a case formulation is have that lead us to more effective ways to interact and to develop treatment strategies and for that person and for that system. Thank you all. Okay, another big thing we have to always consider, and this is one of the other kind of guiding principles or key parts of how the START teams operate, is from a trauma-informed care perspective. So we have to consider trauma in IDD and realize that a lot of people with IDD have experienced trauma. They are 4 to 10 times more likely to be sexually abused. So we think about those big T's: physical abuse, sexual abuse, accidents, those kind of things, but they also are much more likely to experience negative life events. We sometimes kind of think about these little T's or things that we don't automatically think of as trauma, but they experience a lot of negative life events that add up over time and can really be disturbing for folks. So that can include things like hospitalization for medical issues, being sick and being cared for long periods of time, being separated from their family, frequent changes in caregivers, which happens a lot for folks with IDD. And all of these kind of life losses of staff over time can result, or in family members, can result in complicated or traumatic grief. So we have to pay attention to underlying trauma in folks with IDD and always consider that in how we're planning for folks. We know that exposure to traumatic experience disrupts the development of self-regulatory processes. So again, this ties really directly back to when we talked about executive functioning. So people with IDD have some executive functioning differences as a function of having IDD. And then when you think about the trauma that's added on top of that, often it can create more emotional dysregulation, inhibition difficulties, distortion in concepts of their self and others. So trauma adds to some of the things that people with IDD may already be struggling with in terms of executive functioning. Some of the biopsychosocial factors that contribute to this, again, I've already mentioned some of these, but socially people are kind of trained to be more compliant. So we don't give people enough education around sex education, education around themselves, their bodies. There's often not provided with that. People are dependent on caregivers. So social factors certainly contribute. Biologically, there's some factors. We covered some of these earlier, but just impaired mobility or health needs. And then psychologically, cognitively, again, we know from studies that level of intellectual disability influences the likelihood that you'll be exposed to traumatic experiences, and it also increases the risk that PTSD will be developed as a result of that. So this is a very brief talk about trauma. There's lots more to talk about trauma, but what I want you to take from it is that the people that we work with often have experienced traumatic events during their life. Not every one of them who's experienced those traumatic events will develop PTSD, but people who have experienced traumatic events do have long-lasting effects due to trauma. So at START, we believe that we need to presume that clients we serve have a history of traumatic stress and exercise universal precautions. That means that we react and we plan and we strategize and we work to develop treatments for folks based on a concept of trauma-informed care. We do not want to re-traumatize people, and we want to be aware of the things that have been traumatic for them in the past. So the last little area I'll cover is just a concept called cognitive reserve. And our cognitive reserve is our ability to function in situations where you're exposed to unexpected life events and unexpected stress, and being able to call upon, and again, this is all related to executive functioning and trauma and the things we've all talked about, but that ability to develop ways to cope, ways to get through difficult situations and when unexpected things happen. And in general, people with IDD have less cognitive reserve. Some of that because of executive functioning, some of that because of trauma, some of that because of social factors that Karen will probably mention soon, of just having less social support around you, because that also helps all of us with kind of our ability to get through difficult situations.
So Jill, can I stop you for a minute? There's been, there's some comments that that we as trainers today are not talking about what to do, but really why we do it and what our underpinnings are. And I just want to remind everyone that this is an orientation and that full training on all of these issues occurs. Can you speak a little bit more about why you're presenting the information you're presenting today, and why is it relevant to understanding START?
Yeah, so we want to know what the why of things. So we do a lot of work around understanding what's behind somebody's presentation. So this part is important. We spend a lot of time in assessment and understanding, again, the whys of the presentation of somebody that's presenting for services because of crisis utilization and those kind of things. So until we understand that, it's hard to shift the perspective of how people see that person unless we understand the underlying vulnerabilities. And as I said before, the reason we want to do a biopsychosocial formulation is because we want to understand all those factors that contribute to the person's presentation, so that when we develop strategies, they match what we've discovered. So it does feel like a lot of work, and it is a lot of work, and we take that time to really be curious about what's underlying some of these difficulties. It doesn't mean, and like Joni said, we're not getting into the whole operations of how START team operates. It doesn't mean that we don't pay attention to current situations. We're a crisis team, so we do respond immediately to try to stabilize, but we also are always thinking about going back and what's behind this and under this, so that we can develop more effective strategies moving forward.
So, for example, somebody asked why you're not talking about EMDR. This is what we see all the time, where people try to get the START coordinator to talk about the specific strategy they're going to use, instead of a whole person perspective on looking at things from various elements before even talking about, well, what are we going to do about it, and what are the treatment approaches? This is the orientation to looking at all the ways in which we look at people and we teach to consider, so that people don't say, well, oh, the person suffers from trauma, EMDR is the answer, and everything will be fine as soon as you start using EMDR. Can you speak to that a little bit, Jill?
Yeah, and from a broader perspective, trauma-informed care is what I was talking about in terms of understanding the impact of trauma on somebody's presentation, right? So that we can do that, and that's what we train the teams to do. We can be trauma-informed and understand that from the beginning. But as Joni said, then that leads us to think about what is the appropriate strategy. Yes, we are not an EMDR team. I'm trained in EMDR, and that can be effective for some people, but we really want to investigate and know that person well before we make any recommendations or work with the system on where to move with that. And we also, so EMDR might be, in that example, a good treatment for this person. We also want to continue to work with the people that are around that person, right? So that they understand the trauma-informed perspective, they understand the vulnerabilities around that person, because there's other things we can do on a day-to-day basis with that person to support them and address some of the vulnerabilities that are there. Does that help?
Thank you, yes.
And I know I need to pass it on to Karen in just a minute. This is just I had a slide of the brain, so it's hard for me to not talk about the brain when we're talking about trauma, but I'm going to skip that and just move to this, because I think this kind of helps us to conceptualize kind of all these ways that these different parts of psychological vulnerabilities affect people with IDD. We all kind of have this window of tolerance, which is the place where we operate, where we can think and feel at the same time. So things can go wrong, we can be upset, but we can still think through and problem solve and get through on a day-to-day basis. There are times for all of us when our ability to think and feel at the same time gets impaired because of so much stress or something happening really unexpectedly, and we can become really hyper aware, vigilant, react really intensely with our emotions, and feel overwhelmed, right? So that can happen to all of us at any time. Generally, when your window of tolerance is bigger, you go out of that window a little bit, and you can recover, like I mentioned before. You can, your heart rate goes up and you kind of panic, and you may say something to somebody you shouldn't have said, but then you can come back down into kind of your window of tolerance and begin to think and feel again. When you have psychological vulnerabilities, biological vulnerabilities, social vulnerabilities, these vulnerabilities we're talking about, often your window of tolerance is a little bit smaller, and you're more easily go into that hyperarousal state, right? So you become very vigilant, have very quick reactions to things, feel unsafe, be afraid. And for people with intellectual and developmental disabilities, often, and if they've had trauma particularly, the ability to come back into the window of tolerance takes a little longer. So I should have another chart just to show that sometimes it takes longer to come back into that window of tolerance. And when you come back in, you may not come all the way back down. So you're kind of still at that little black dotted line. So when you come back in, you can quickly kind of go back up into that realm of feeling unsafe. So what we do within START is two things. One, we're trying to look at the environment and see if there's things that we can change that will help address some of the underlying vulnerabilities. We also are trying to increase that window of tolerance. So we're trying to work with that individual to develop some other ways that they learn to regulate some of their emotions, to recognize their emotions. So we do both, right? We're going to approach this from a biopsychosocial perspective and develop strategies around all of that. But our goal is to increase that window of tolerance and also help the system to understand how to respond when somebody goes out of that window of tolerance. So this visual, often the coordinators will sometimes use this trying to explain what we're trying to do and how that person is reacting to things and why they're reacting in that way. And it's not because they're trying to manipulate somebody or take advantage of somebody or intentionally make your day go poorly, but they're dealing with some underlying vulnerabilities that are creating difficulty for them in that moment. So yeah, and again, I know this is an overview, as Joni has said many times, but these are the kind of things that we're teaching people to think about and to ask questions about, because it leads to more effective planning and treatment for folks. I think there's one more polling question, and then Karen will move into the social vulnerability section. You got it. Thank you all. Yep, that's just a recap, and then we'll, Karen, you're up next.
All right, thanks, Jill. Let me share my screen real quick. I know we're kind of running behind, guys, but we'll just kind of go over this. Let me make sure I get it on the right slide. There.
Karen, can we take a break and just address a couple other questions that have come up in the chat?
Absolutely. Let's do it.
There was one question about whether or not there is a best practice for removing an incorrect diagnosis from a record so that the person is getting the proper care.
The way that we do that is our START teams work with the existing system of care to examine the current diagnoses, consider new or different or perhaps more appropriate ones, and work with all the professionals within that realm, and the treating providers, to come to an agreement about what we're seeing and a common understanding of the person. So it's a process. It's not like somebody comes in and says, I'm changing this today. It's the fact that we continue to join with that system. We have clinical directors who are psychologists who help our coordinators do this, medical directors who also help our coordinators do this, and sometimes provide direct consultation to providers, like Dr. McLaren mentioned earlier, to help clarify it. So it's a process. It's a process. First, you have to develop a relationship, then you move towards that conversation.
And I would add that the diagnosis that people have in their historical record has affected the impact on their life and treatment, so that even if it's not accurate, it kind of gives you an understanding of why people did what they did at the time, and what maybe sometimes mistakes were made that really need to be considered moving forward. So it's not necessarily, it shouldn't be like on their permanent record, like it means that it's absolutely the truth, but it does tell you what may have been misunderstood in the past and what the person has gone through. Can you speak a little bit about that and what your experience has been with that, Dr. Weigle?
Yes, yes. You're absolutely right, Joni, that when we have that history, it then helps us to understand, to look back and consider, anyway, question, what was that person presenting like at that time? How did their system understand them? What else was happening during that time, so that we can understand perhaps why they're on specific medications or why certain interventions and supports were put in place. It helps us to understand from that person's perspective as best we can what happened to them, and learn their story from the inside out as much as possible.
Thank you, Dr. Weigle. There's one other question that was in the chat box. And someone was wondering if there were any comments on the use of manual restraint with individuals who have a trauma history.
Yeah, I would comment that that would not be recommended for anybody with or without a trauma history, because you may be creating trauma if you use physical restraints at this time. And I'm not talking about things that may be prescribed by an occupational therapist, which are like sensory input, bear hugs, those types of things that somebody has evaluated from a sensory perspective and understands that that's actually calming for the person. But to put your hands on somebody and use restraint, we would definitely recommend against doing that in all cases. Yeah. Is that it?
Thank you. That's it.
You're welcome. You're welcome. Okay, so really quickly, looking at the time, we're behind a little bit, but I wanted to touch on the social factors that we need to consider in our biopsychosocial formulation of a person. So going back to the beginning, right, we have to start with collateral information and understand the person and what they look like when they're doing their best and on an average day, and start to wonder what's the difference from that point to what we're seeing today, where the presenting problem has been brought up, right? We talked about the biological factors, the medical factors that we really need to rule out and pay attention to probably first among all things. We talked about psychological factors and how that can impact our behavior. It's important to look deeper. We always, I think a lot of people in our field and working with people with IDD tend to jump to the social factors before looking at biological and psychological and really sort of parsing those out and how they all interact. So we want to make sure that we hit those first and never forget the social impacts as well. Also very important. So most often they're equally important, but if we are working on something in the person's environment and or around their quality of life, and they continue to have a toothache or seizures, they're untreated, we're not going to have any effect. If somebody is depressed to the point where it's considered major depressive disorder, some of our interventions may not be appropriate or useful until we get some other help. So one of the first things we need to consider, and I know Dr. McLaren brought this up earlier, was we have to understand the individual's disability and how it impacts them and their family. So we can't overlook this. For some people, their disability or diagnosis or mental health concern is a real part of their identity. I know some adults with autism autistic adults who prefer that I call them an autistic adult, who are advocates and very passionate about acceptance and promoting authenticity. So that's somebody who may be very in tune with that part of themselves. Their autism may be a big part of their identity. There's also other people I know that maybe have autism or another intellectual disability and don't really identify as that. It's not really important in the way they view themselves or the way their family views them. So we need to first consider that, but there are also multiple cultural identities that we all have and that we all need to consider with each person that we work with and their families. So it can be religion, race, national origin, language, class, gender identity. There are multiple identities that we all carry around and cultural histories that we have. And we can't make assumptions based on first meeting somebody or looking at them, what those are. So it's really important when our START teams get to know the clients and their families to really investigate this deeply and try to understand and come from that person's perspective. Think about, for those of you who are providers, how many times maybe in the past you've come in, met somebody, done your formal assessment, and you have some really good ideas for intervention and you try to use those, and then they don't work, right? For some reason, they're not happening, or the family's not adhering to what you're doing, or somebody's not following up and doing the homework you asked them to do. More than likely, it's because you did not consider the cultural perspective, that person's perspective, their values, what they want, how they do things, and how it fits into their life. So these are aspects of the work that our START team does that is critical to being effective. So the population that we work with, people with intellectual and developmental disabilities, especially those with mental health needs as well, have a lot of social stressors that we need to consider. So isolation, loss of relationships. I think I saw in the chat earlier that somebody mentioned, what about all those moves? What about people losing staff? If you're an adult in a group home, roommates moving in and out, that's a lot of loss. Even moving out of your family's home can be a loss. So it happens a lot that people come in and out of people's lives, and it's important to consider that and how that impacts the person. There are a lot of everyday micro inequities and minor traumatic experiences that add up to a lifelong of expecting the worst. And this made me think, when Jill was talking about trauma, also that level, that threshold level where you can tolerate, that tolerance, the window of tolerance is changed by lifelong micro inequities, things that continually happen, and then you are set up to expect those things to happen, and therefore you automatically react that way. Your body does, through the limbic system, through the brainstem. And I know Jill didn't have time to get into the brain stuff, but it is not a decision. It is your brain's reaction. Also, a lot of people that we work with do not have the opportunity to give back and contribute and feel fulfilled. Think about what yesterday we talked about, what would happen. I think Dan brought up what would happen if you weren't able to do the things that were based on your strengths, right? You aren't able to do the job you love or share the time with your family you love, whatever it is that you love to do. What if you couldn't do that for a year? How would you feel? And I think that happens a lot with the people we're working with. They are most often doing things that are available and accessible to them, maybe not appropriate. So going back to the 3 A's, it may not really be what's right for them, but hey, there's a spot at this school or in this, this day program. So that really makes an impact on us and our daily well-being and our wellness. Lack of satisfying reciprocal relationships. Again, if people are sort of choosing where you're going and what you're doing, and it may not be really something that speaks to you or resonates with you or brings you joy, you may also have more difficulty making relationships in that context or making friends. It's very important. Boredom. We all know that that is really difficult. And the history of rejection and marginalization that our clients experience is significant. One more look at the biopsychosocial. Just as a reminder, remember, we're looking at mental wellness. This is where we want to bring people as a start team. We want to bring the person and their entire system into this realm. So what can we do about it? Let's go back to something we talked about yesterday again, is that PERMA. So here are some things we can do. While we are addressing all the biopsychosocial vulnerabilities of this person to the best of our ability, while we are clarifying diagnoses, while we are checking on medication side effects, while we are ensuring that every medical problem is addressed to the best of our ability, while we are thinking about somebody's executive functioning and putting strategies in place to support it, while we are considering the person's mental health conditions if they have them and how we can best address those, we are also continually promoting PERMA. So this is the biggest piece of addressing that social part in a person's life. How do we get them into situations and with people that they get to experience on a very regular basis, daily basis, positive emotions, engagement in what they're doing, positive relationships, meaning, and accomplishments. How do we help people get there? That is the key. I think I went pretty quick. Polling question, really quick. Biopsychosocial model is primarily important for assessment. Would you say that's true or false? Okay, I'm gonna end it because this is a lot of feedback. Okay, so it looks like I have to back up. About over half of the people said true, and about 41% of you said false. And actually, it's false because it's not only critical for assessment, it is critical for ongoing development of interventions and supports. So it's ongoing. We always need to be considering these things. Maybe that is reevaluating continually, but we need to think about how we're going to address biopsychosocial factors in our interventions. All right. So
Karen,
now,
Dr. Weigle.
yes.
There has been a couple comments in the chat box around the role of behavior analysis and behavioral support within the context of START. And I'm wondering if you would take a moment to just sort of share your own background.
Yeah, yes.
People are thinking we're humiliating behaviorists and don't believe in them, and
no,
and Karen is a behaviorist, so I thought you might add that.
That's good. I'm a good person to talk to about this. No, not at all. I am a clinical psychologist, but I went to school at West Virginia University, which is a very behavioral program, especially in the child clinical and the behavior analysis programs there. And I'm definitely a behaviorist and a cognitive behaviorist, depending on who I'm working with. But the thing that I learned in graduate school and continue to to value is the fact that we can't only consider, I know in behavior analysis, a very strict ABA, you only want to consider variables that you can observe with your eye. When we do that, and when I've done that in the past, you miss a whole lot. You're missing the potential biological factors and the psychological factors. So you have to think of those as setting events, antecedents, and consequences potentially to be all of those. So when you think about this biopsychosocial assessment that we're doing, it's really an expansion of a functional analysis, or a functional assessment, I'm sorry, not analysis, a functional assessment. So it's an expansion by including these other factors that we know impact people, right? Like, I know that I'm not grouchy to my kids every day, but if I have a headache, I might be grouchy. If I have a headache and something really challenging or negative happened at work, I'm even more likely to be grouchy or yell. So think about the things that occur biologically, psychologically. If I'm anxious, then I'm even more likely to bite somebody's head off in my family, right? So we all know these things, and the START model is just wider and broader, trying to include all of those pieces. And we often work with behavior analysts, and they've done a lot of our legwork at that point by looking a lot at the social factors. But again, we reframe things from being non-compliant to being independent. And maybe sometimes it's dangerous for this person to be as independent as they would like to be in some situations. So then we need to address that about where can we increase independence somewhere else, and then negotiate around their independence when it's dangerous. So we're not saying no behavior analysis. We actually are doing it in a way, just an expanded way.
So can I add one thing to that, Karen?
Sure.
I think we're behavior analysts for all of us, though, not just for people with IDD. So I think the difference between our approach and people who perhaps collide with us a little bit, or we collide with a little bit, is I think my behavior needs to be analyzed too. And I think the behavior of families need to be analyzed, and the doctor, and even the behavior analyst, and that we all come in with biases and assumptions, and that the person with IDD presents as a human who articulates their humanity through behaviors just like the rest of us. So we do engage in behavioral analysis, but it's a much wider scope of behavioral analysis. We look at the psychosocial context for all of us. And if you don't want to be talked about based on your behavior, then we're not going to talk about people with IDD based on their behavior. Doesn't mean we're not looking at it. It just means we're thinking about how to explore that in a more respectful way for all of us.
Right. And I think that's a really important point, Joni, right? Is that, so another aspect of the START model, at least the way I thought about it when I first was learning about it, and still kind of do, is to take that behavior analysis and put it on the system, right? I'm looking at that systemic interaction and who's doing what, why are the people interacting the way they are. We're not talking about this now because we're not teaching the model, but that is what we teach the coordinators to do, is assess that bigger system in a very comprehensive way and figure out how to help everybody communicate better, understand better, and therefore change their behavior to best support this person and to feel better themselves. Because most of the time when we're working with these systems, it's not good. They're not happy. Things aren't easy. So we're there to try and help everybody.
So the other point that someone's making here is that it's very hard to be comprehensive when the person can't speak for themselves. And I think Jill was talking about how, and Dr. McLaren, that people are speaking for themselves. We're just not hearing them. So that's one thing. And the other thing is the full history is absolutely important, as the person articulated, but we just really need to And we need to just be explorers and try to get as much information as we can. And when people start practices, you'll see the importance of record review, history, getting that information and data. So thank you for taking this pause, Karen, because there's a lot being discussed on chat that needed to be addressed. Thank you.
Okay, sure. Did I do something? Sorry, guys. I don't know what I did to the slide. Bumped it. Okay, so we finished the polling question. Thanks for that. That was an important interruption. I think really important conversation and questions. And I know we could talk about it for probably another 12 hours. So those of you who are interested, I hope to meet with you someday when we can and do that. All right. So we have one more vignette that we'd like for you guys to read. You know, this is available online. I know that once we got into our room, some people were wondering, like, I didn't remember the details of the vignette. Or you can just take a picture of it with your phone right now or screenshot it for reference in our small group discussions. I will read it to you because I know everybody loves that. Julie is a 32-year-old female with mild intellectual disorder. She has a history of several psychiatric diagnoses, including anxiety, borderline personality disorder, depression, oppositional defiant disorder, attention deficit hyperactivity disorder. These multiple psychiatric diagnoses are the result of her frequent emergency room and hospital visits. She also has been diagnosed with GERD and IBS. She's a strong, capable, loving, and helpful woman who currently lives in a group home with 3 other women. She maintains a close relationship with her adoptive parents and loves being helpful to others and feeling like she has a purpose in her environment. Remember we talked about PERMA, don't we all? She's talented. I'm looking over one screen to the other. She's a talented artist and does beautiful pencil sketches of people in her life. Oh, went one too far. Excuse me. All right. Julie struggles with mood dysregulation and has episodes of self-injury and verbal aggression. When she's most distressed, she leaves her home abruptly, and there are concerns about her safety in the community. She often reports pain and other medical concerns, which result in frequent visits to the emergency department. Julie was adopted when she was 3 years old from another country where she'd lived in an orphanage since infancy. Julie experienced a significant trauma later in her life when she was raped on the school bus. That's as much as we know about Julie right now. And now we'd like for you to break into your small groups with discussions. I think that the questions will be posted for you in the chat so that you can see them.
So we talked about how most of what we heard met the diagnostic criteria for PTSD. And we wondered whether or not she was becoming dysregulated, and that there were things that we didn't know that created that form of dysregulation that causes you to have fight or flight, self-harm, and some of the other issues that she faced. And people in our group were very impressed by the fact that she was creative and had really good skills, you know, and that she liked to be helpful, and that she had a lot of resilience. People talked about her resilience. And one person said, you know, it's really hard to tell about what to do without talking to her first. And that was sort of, it was, yeah, it was, yeah.
Okay, that's great. Really nice. I think, you know, I wish we had more time to chat and hear from more groups, but I appreciate those of you who did contribute. And this is just one last slide around connecting our biopsychosocial approach to PERMA. So for START teams, this is our assessment, our beginning assessment and ongoing assessment throughout our interventions with a person and their system. And we use specific strategies to address those vulnerabilities. In the meantime, remember I said we are also continuing to help promote PERMA and help people achieve PERMA in their life. In summary, So thank you all for coming today. I know it's 1 minute past when we're supposed to be here. I so appreciate you being here. We hope to see you guys tomorrow. Thank you.